Joseph Medical Center. Thank you to everybody on Skype for joining us today. Normally this is the point where I introduce the speaker, but today I am the speaker. So I'm going to give you just a brief little bit of my own background, and then we'll hop into our topic for the day. For those of you who don't know me or don't know me well enough, I'm Dr. Chad Thomas. I work over at Peace Health Medical Group. I did my medical school training in University of Illinois because that's where I got in. And then came back to University of Washington for medical school. I've been up here since finishing residency at the UW, and currently I'm the section lead for obstetrics and gynecology over at the Peace Health OB/GYN clinic, as well as adjunct faculty at the University of Washington because of the medical student teaching we do. So today we're going to be talking about cutting back on the quote-unquote good stuff and how we can reduce opioid prescribing in obstetrics and gynecology. I wanted to give the usual disclosures. First off, I like chocolate chip cookies way too much. For that matter, I also like lemon bars, brownies, and just about any other baked good. But otherwise, I don't work for anybody besides Peace Health, and I'm not going to try to sell you anything. I want to give a little bit of a background on how I got interested in this material. It really came back to one particular patient whose story I'm going to tell, who I've taken care of for almost as long as I've worked here. And after I had a particular interaction with her was when Peace Health started rolling out its opioid task force, and I said, you know, this would be a good way that I can contribute. So that's how I ended up at the point that we were giving this presentation. So this is a 28-year-old G3P0111 female. She had a preterm delivery at 35 weeks for her first pregnancy, came to see me for her second pregnancy because she was pregnant with Di twins. Her medical history was complicated by smoking and depression, but otherwise fairly uncomplicated, pleasant, sweet patient. Developed persistent back pain, which got worse, and by the third trimester, it was unresponsive to everything that we'd tried. We tried Tylenol, heat, physical therapy, maternity belts, nothing was working. So I said, okay, I'm going to do what I don't usually do and get you started on Vicodin. It didn't help a lot. It helped a little. She continued to take it intermittently throughout the pregnancy. Little did I know that was going to be the beginning of a much longer road. She ultimately ended up delivering at 32 weeks by C-section for a preterm premature rupture of membranes down at the university. During her postpartum time, she quit smoking. She had a wound infection, some postpartum depression, needed extended narcotics because of the additional pain from the wound infection, but otherwise did really well, got off of her narcotics by 6-week postpartum. A couple years later, she was back, pregnant again. This time was a singleton. In the interim, she had developed chronic migraines for which she was on Topamax, but because she couldn't take that while she was pregnant, we got her started on Percocet as needed for her migraines. Also Vicodin for her back pain. She was smoking again. This time, progesterone was our friend. She went to term, had a C-section, another wound infection, another prolonged postoperative course, more Percocet, but ultimately got off of her narcotics again by the end of her 6-week postpartum course. Cycle continued to repeat itself. In between pregnancies, she had painful periods, was given some Vicodin, switched over to Tramadol by a different provider, multiple ED visits, abdominal pain, back pain, painful periods. You can see where this is going. Treated with narcotics many times. By the time she got pregnant again for the third pregnancy that I was taking care of her for, she continued to have chronic migraines, depression, and smoking. Was on Vicodin again for her headaches. Back pain got worse earlier and earlier every single pregnancy. And so by the end of this pregnancy, she was on twice-a-day oxycodone. She was on gabapentin for pain control. Delivery, once again, C-section at term. Baby predictably spent time in the nursery, withdrawing from the gabapentin, withdrawing from the narcotics. Mom seemed to do okay, disappeared for another couple of years, came back to see me again with yet another pregnancy, now pregnancy number 4. And this time, when I saw her at her first prenatal visit for the pregnancy, after the usual congratulations, she told me, I realized that I was an addict and I needed to get treatment, and she'd gotten started on Suboxone in the interim. And that hit me like a ton of bricks because I'd been the one who had prescribed most of her narcotics over her previous 3 pregnancies. So this pregnancy went really well, tied her tubes at the end of it, so she's not coming back to see me for any more pregnancies, but she didn't need any short-acting opioids. The Suboxone was all she needed. She was managed very well through the whole pregnancy, did fine. She came back to see me for another issue a couple months ago and told me some very sad news, and that was that her partner had recently died of a heroin overdose. Now, he had his own demons and had struggled with opiates for as long as I'd known her. But this really shows the 2 possible outcomes for our patients. They can get help, or sometimes they end up dead. And so this was the patient that made me start thinking about opiates and what we do to our patients. I've had lots of patients on chronic opiates. I've had patients on higher doses of opiates than this person. I think we have to balance taking care of our patients and treating their pain, but also finding a way that we can treat it with the minimum amount of medication so that we aren't stuck with side effects that take us down roads that we don't want to go. So speaking of roads, let's talk about our roadmap for the day and where we're going to be going. We'll start off by talking about just how bad it is. We'll look at opioid prescribing in OB. We're going to talk a little bit about GYN. I'm going to spend less time on the GYN, mostly because the data is much clearer than OB, and also because most of us do primarily OB, and it's only the OB-GYNs in the room who are doing GYN. We're going to talk about strategies for minimizing opiate use, and then look at some of the difficult situations and tips and tricks that I've gleaned out of all the research that I did for this talk. So let's start with just how bad it is. I'm going to come back to this graph a little later, but the take home is opioid prescribing has risen over time for the same procedures. This shows you a 10-year period of time from 2004 to 2014, and what you can see is that the number of opioids prescribed increased 5-fold in that time. And this is looking specifically at hysterectomy, so we'll come back to it in a little bit. The other thing that we've found is that many patients are sent home from the hospital with opioid prescriptions when they haven't actually been taking it in the hospital. This is called overprescribing, and we're trying to thread the needle here. We don't want to overprescribe, and we don't want to underprescribe. So for this particular graph, it's fascinating. Most patients in the hospital who are on opioids, they get sent home on something similar to what they're taking. However, there's 2 outlying groups that I wanted to highlight. One is the group down at the very bottom of the slide who are discharged on no opioids despite taking potentially lots in the hospital. Now, presumably these are people who are coming in for scheduled procedures, had gotten narcotic prescriptions ahead of time, so they didn't need to fill them when they went home. That's great for our patients because it means they don't have to stop at the pharmacy on the way home with a paper prescription, but there's one problem that we overlook, and that is that we're guessing at how much opioid they're going to need at discharge. Because as you can see, there's a huge range. Some of these patients aren't needing any opioids at discharge. Other of them are needing enormous amounts. And what we find is that for any particular procedure, the amount that people need varies. So much as it's convenient to send patients home with their narcotics on the front end, I actually don't recommend that we do that. And this is going to get easier for us as electronic prescribing for narcotics gets rolled out. I know it's integrated with some of people's EMRs. It's coming to Care Connect in the next year or 2. And then we'll be able to actually get that prescription to the pharmacy electronically so that the patient doesn't need a hard copy and it can be filled by the time they get there. The other group of patients I want to point out is this group. This is the overprescription group. These are patients who are not taking any narcotics in the hospital for 24 hours before discharge, and yet are discharged with up to 10,000 morphine equivalents of narcotic That's an enormous amount. Now, some of these patients may have had nerve blocks. Maybe they're not having any pain, but we're anticipating they're going to have pain. But I know most nerve blocks wear off within 24 hours. For our patients, we're usually seeing them at their pain level that they're going to have when they go home. So let's look at how bad it is in OB/GYN. I want to start with the graph over here. Gynecology's up here, OB is over here. Most of our patients are taking opioids before discharge. That's what's on this axis. And we're out at 60 to 85% of our patients. However, more than that percentage of our patients are going home on opioids. And so this suggests that we're overprescribing. And we want to be careful here because in OB and GYN, we have the possibility of making a really big difference in people's lives. We have the most common reason people are hospitalized, which is a vaginal delivery. We have the most common surgery, which is a C-section. We have the most common non-obstetric surgery, which is a hysterectomy. So if we change our prescribing habits, we make the biggest difference of anybody on this list. If you look at the data, what we find is that 1 in 300 patients who has a C-section will become a persistent opioid user. Here at St. Joe's, we do roughly 700, 800 C-sections a year. That means that 2 to 3 patients every year are becoming persistent opioid users. I pointed out a story from at least one of them. I'm sure you may be able to think of others in your practice. Risk factors are things that I pointed out in my case presentation. Anxiety, depression, smoking. These are the things that actually correlate more than anything else with how much opioids people prescribe and how much that they need. It doesn't correlate as much with procedure. I also recently finished this book, which I would encourage everybody to read if you haven't already. It's a story of a critical care physician who got extremely sick, conveniently in pregnancy, at 27 weeks. Originally was misdiagnosed with HELP, ultimately ended up finding out that she had a hepatic adenoma. Had about a 2-year course for recovery from a massive replacement of her blood volume, was on chronic narcotics. This is her description of what withdrawal from opioids looked like in her life. After 72 hours without medication, I began shaking with chills and my muscles ached with a bone-deep soreness. My stomach churned and excreted an acidic taste that I knew heralded vomiting. My skin was covered with goosebumps. Rivulets of sweat poured off me. Though I had no psychological dependence on the medications, my body had become habituated to them. And I think this is the big take-home. She doesn't have a problem with persistent opioid use because she's developed a craving for them. Her problem was that her body developed a tolerance to it just from being on them long-term. And we'll see this in our patients who are on chronic narcotics. After about 5 days of chronic narcotics, patients start showing signs of withdrawal and tolerance. So one question is why not just prescribe people plenty of opioids so they don't run out and counsel them well not to take any more than they need? The problem is that we don't get rid of them after we're prescribed them. Less than 10% of people dispose of leftover opioids. If you ask your patients what their plan is, a third of them don't have a plan. 10% of them get rid of them, and the other half are planning on saving them for later because we're worried we're going to have pain in the future. The other problem is it's hard to dispose of opioids. You can't just take them to a medication take-back. You're not supposed to dump them down the toilet. Your options are either you mix them in with kitty litter and then throw them out, or you take them to the police station. And this is hard for most of our patients to do. When my daughter was treated for pediatric cancer, we ended up with enormous amounts of liquid oxycodone. It took us a year to get rid of it because, well, you never know when you were going to need it. And then ultimately, I have to make a special trip down to the police station. And then you get there and you get a secretary who doesn't know what you're talking about. So we do need to be counseling our patients better about disposal. We also need to be working on finding easier ways to make it able for them to dispose of these. When people save them, then they share them. So that's what this graph shows. This is national data. half of the times people who are abusing opioids get them from somebody they know, friend, relative. And it's not that they stole them most of the time. It's that someone said, oh, you're in pain, here, try this, it'll help you. The other primary place of getting them is from us, one physician. So they come and see you, they've seen you for years. You go, yes, I know your background, you're a good person, I know you're not going to get hooked on these, here, let me help you out. Very rarely are we getting patients who are getting them from more than one doctor, who are stealing them from somewhere or buying them off of the street. So we are the source of the majority of this problem. Now, before we go any farther, I want to talk a little bit about converting between opioids. If you read the literature, everything is in milligram morphine equivalents, which is a pain to say and also isn't helpful for us because we don't use morphine very often here. Since we mostly use oxycodone through Peace Health, and that's one of the two standards on our order sets, I converted everything in this talk to oxycodone because it helps us know how much we're using. The conversion between hydrocodone and oxycodone is very close. So if you like to use Vicodin instead, it's almost 1-to-1. Oxycodone's a little bit stronger. When you're switching a patient between opioids, I know everyone pretty much does this anyway, but please don't assume you can just put a mathematical equation in and convert people. Aim low and then titrate back up because people do respond to opioids differently. And then quick reminder, please don't breastfeed on codeine. All right, let's look at OB. For vaginal deliveries, 80% of patients receive opiates in the hospital when they go on to have a vaginal delivery. Now, this may be clouded by all of our patients who get fentanyl while they're in labor. So I don't want to stress that number too much, but 30% of people across the country go home on opiates after a vaginal delivery. And the median prescription that they're sent home with is 20 tablets of oxycodone. Only 20% of the patients who are sent home on opiates, though, had some bigger reason for pain, like a tubal ligation or a higher level tear. So if you look at the patients who go home, 80% of those people just had a normal vaginal delivery. Many of these are primates. They're not even multips who may have more cramping. Now, I'd love to be able to say, oh, it's a problem from somewhere else in the country. Unfortunately, if you look at prescribing across the country, you see a lot in the South. You also see a lot in the West, including Washington State. So we are certainly included in this. If you look at C-sections, your average OB patient takes 6.5 oxycodone a day while they're in the hospital. That exceeds the 30 milligrams of oxycodone that's the recommended maximum for breastfeeding. Now, most of our patients do very well. We haven't had babies who have gotten overly sleepy from oxycodone. Obviously, we're watching all of the patients in the hospital, but these are the national recommendations. One of the things I didn't realize before doing this was how long my patients stayed on oxycodone after a C-section. I assumed, it probably takes them about 2 weeks to come off because by the time I see them back 2 weeks later, they're mostly off of it. In reality, average use is about 8 days postpartum. And 85% of our patients, unsurprisingly, are discharged on opiates. Typical prescriptions across the country range from 30 to 40 tablets. Interestingly, the amount the patient uses correlates very well with the amount that they are prescribed and not as well with the amount of pain that they have. So if you prescribe them 40 tablets, they will take more than if you prescribed 20 tablets. If you prescribed 60 tablets, they'll take more than if you prescribed 40 tablets. The reason for this is quite simple. We've actually succeeded at convincing our patients some of the time that they should take their medication as it's prescribed. So they get a prescription and it says 1 to 2 every 4 hours and they say, okay, I took it just like you prescribed, doctor, and that's why I'm out 5 days later and I need a refill on this. That works really well for antibiotics. It's not what we want them doing with narcotics. So where we're failing is we're failing in communicating how to taper off of their narcotics and how they should take them. Looking at GYN, here's that graph I showed earlier. What we found is that the amount of narcotic prescribing increased from 25% of patients undergoing GYN surgeries to 80% of patients. And this is while the rate of abdominal hysterectomy fell from 60% down to 25%. So we're doing less invasive surgery and prescribing more narcotics, and patients have typically less pain after less invasive surgery. So how do we minimize prescribing? Because this is ultimately where the rubber meets the road for us. First thing we can do is schedule medications. We're generally pretty good at scheduling ibuprofen and Tylenol. It's built into the order sets to be scheduled. Occasionally you'll get some pushback from the nurses because it gives them flags, but I would encourage everybody, schedule your medication, schedule your ibuprofen, schedule your Tylenol. In some cases, scheduling your narcotic can be helpful. We'll get to there, but for the most part, don't schedule your narcotic because these are the ones we want patients taking as needed, at the lowest dose that they need. But encourage your nurses to make sure that they're going in to check in on the patient's pain every time that narcotic is due so that we can stay on top of the pain and their patients aren't going for 6 hours in between narcotic doses when they really need to be redosed at 4. Because when we dose patients more frequently, they end up with better pain control, they end up using less. If there's scheduled procedures, we can use pre-op medications. These can decrease post-op pain by up to 50%. Interestingly, if you look at the question of IV medication versus oral medications prior to procedure, there's no significant benefit to IV medications. There's one head-to-head study out there for IV Tylenol versus oral Tylenol. Smallish study with about 60 patients. They found no difference between the two. Now, most of these have been done in scheduled procedures, so there's always the question, is a patient who's having a section in labor different? Maybe, but I've recently switched over to just doing orals. I haven't seen any different in my patients. The other thing we want to do is after whatever procedure the patient has, we want to be using multimodal therapy. And this is where we're going to be spending most of our time talking about how we can optimize treatment for our patients. Most of the time, multimodal therapy is going to be lots of different ways of addressing pain so that we're targeting different sorts of pain receptors and minimizing the amount of medication that patients need. Primarily that's Tylenol and NSAIDs for us. If you look at Tylenol versus no Tylenol, we find that it cuts opioid use by about 20%. There's no reason not to be prescribing Tylenol on a scheduled basis for our patients, with a couple of exceptions. And those are uncompensated cirrhosis and patients who have active liver disease. Hepatitis C, hepatitis B, even with elevated LFTs, you can still use Tylenol. We see some of these patients. We don't need to be scared about prescribing Tylenol for them. You do want to decrease your upper limit of how much you give, but you can give up to 2 grams a day. For NSAIDs, we find that these decrease opioid use by 30 to 50%. They're okay to use with things where we've typically held back, like pregnancy-induced hypertension, preeclampsia. It does not worsen patients' hypertension. Yes, you want to make sure the patient's well hydrated so you don't end up having a kidney injury from having a dehydrated patient using NSAIDs. But as long as they're hydrated, you're fine. Same thing goes for hemorrhage. As long as you're not worried about active bleeding, we should be giving patients NSAIDs after a postpartum hemorrhage. Because once again, it will help decrease their vaginal bleeding and it will help with their pain control. A lot of patients say, hey, I have an allergy. Explore those allergies with your patients. Most of them is, you know, it irritates my stomach after I took 800 milligrams of ibuprofen every 4 hours for 3 weeks straight. That's okay. They can take ibuprofen. You just want to make sure that they're taking it within the recommended doses. If they have GI intolerance, think about prescribing a PPI along with it. That'll help protect their stomachs. They won't get stomach ulcers, and they'll have better pain control. It'll also help them get off of the NSAIDs faster as we treat their pain. There's a lot of non-opioid adjuvants that we can also add to ibuprofen and Tylenol. We're going to spend some time talking about gabapentin in a moment, but I wanted to point out some of the other ones, such as tricyclic antidepressants, muscle relaxants, benzos we'll talk about a little bit, local anesthetics. Other lesser used ones like ketamine are also options for some of our patients. So what about gabapentin? This is one of the ones that I think is most confusing based on the data that's out there. The first thing is I want to reassure you that while there is a withdrawal syndrome for patients who have used it for a long period of time, we don't see that in all babies. And there are no fetal effects if you give it as a single dose, either pre-op or post-op. So it's reasonable to use short term. After delivery, it does not get significant levels in milk. So it's okay to use while breastfeeding. When you look at the data for cesarean sections and gabapentin, this is where everything gets confusing. There are not a lot of studies. There's basically 3 small studies. One found that there wasn't a significant difference in opioid use, though it decreased the amount of pain. The other 2 found that it decreased both pain and opioid use. So it's unclear what effect it actually has. And it may be from some of the other data looking at other surgical procedures that gabapentin just doesn't work as well when you get outside of a general anesthetic. Because when we look just at patients who had general anesthetics, that's where we see the benefits from gabapentin. And so when we look at hysterectomy, we find that gabapentin reduces opioid use by 30%. We see it also helps with laparoscopic GYN surgeries. It does not help with hysteroscopic GYN surgeries, but then not much helps reduce pain after hysteroscopy because there's just not a lot of pain. As far as dosing goes for gabapentin, there's been studies looking at 150 milligrams, 300 milligrams, 600 milligrams. Generally, you need at least 150 milligrams. The one study that used that did multiple dosing where they had both pre-op and post-op doses. And what we find is that the higher the dose, the more sedation that we see. So if you're going to be giving multiple doses, you may want to think about using the lower doses. Typically, I start at 600 milligrams for the first dose to load the patient and then drop to 300 after that, and most people tolerate it very well. It's unclear how long we should be giving gabapentin. This really hasn't been studied in the surgical literature. What I have found is that for patients who do not have chronic pain, it's unclear if there's benefits beyond a couple of days. So most of my patients where I'm starting it here in the hospital will stop at a discharge and send them home. In patients with chronic pain, these are the people who benefit from longer term treatment with gabapentin, and they may be on it anyway for their chronic pain. So oftentimes I'll continue it for up to 2 weeks there. All right, it's been about a half hour, which means you're no longer paying attention. So I'm going to switch subjects just briefly and give everyone a little history lesson. I married a classicist who studies Greek and Latin, so we talk a lot about etymologies in our house. So we're going to talk about where the term opioid comes from. Obviously, it comes from opium, which is the name of the opium poppy. But why opium poppy? Turns out that opium comes from Greek, unsurprisingly. Specifically, the word opos, which means juice, because opium was originally the juice of the poppy. And so this means, if I can make a really bad joke, that when our patients are on opioids, they are juiced. Sorry. How much should we prescribe? This is really probably the area we can make the biggest difference for our patients going home and making sure there's not too many opioids circulating. So I wanted to take a little survey here. How many people prescribe opiates after a vaginal delivery? Anybody in the room?
Immediately after or
Most of the time. Most of the time. More than 50% of the time. Anyone prescribe it more than 25% of the time? All right, so most people aren't prescribing opiates for vaginal delivery. How about a C-section? Who routinely prescribes opiates after a C-section? All right, so we're going to see how much you prescribe. Anyone only prescribe 10 pills after a C-section? Anyone prescribe 20 pills after a C-section? See a lot of hands for 20. 30 pills? We've got some 30s. Anyone for 40 pills? Anybody ever prescribed 60 pills? I know there was a time where I was doing 60 pills fairly routinely coming out of residency.
Ever is a big word, Chad.
Ever is a big word. I'm sorry. Anyone routinely prescribe 60 pills? There was a time I was doing it for a couple of months. I'm not proud of that. What I would encourage most people to do is think about taking your standard prescription and cutting it in half if you are using 30 to 40 pills as your standard prescription like most of the country does. But a better way of prescribing is not to do one-size-fits-all prescribing, and we're going to talk about that in a second. Better, let's ask, how much is our patient actually using? So how many people look at the MAR before they discharge their patient to see how much they're actually using?
I do now.
So I would strongly encourage everyone to do that because you will be surprised at the variations that we see. The other thing to ask, sorry, I don't know why my last one is disappearing, is what's their patient's pain score in the hospital prior to discharge? So if we look at their pain scores for the 24 hours prior to discharge, if they're using 3 to 4, if their pain scores are 3 to 4, which is most of our patients in the hospital after C-section, they're going to use about 15 tablets of oxycodone after discharge. If their pain scores are a 5 to 6, they use about 23. If they're 7 to 8, they use about 30. So how much should we prescribe in OB? Well, like I said, how much is the patient actually using? For vaginal deliveries, 80 to 90% of patients don't need narcotics, and 30% of patients are going home on them. So there's a discrepancy here. If we look at tubal ligations, most patients don't need narcotics there either. What I've found is that for my patients who have a vaginal delivery or a vaginal delivery and a tubal ligation, I typically just do scheduled ibuprofen and Tylenol. I do not write for narcotics because I want the nurse to call me if the patient needs it. And what I've found is that I have gotten a handful of phone calls in the last 6 months. I can probably count them on one hand. Because with ibuprofen and Tylenol together, these are about as effective as hydrocodone. And most patients' pain is very well controlled with it. For cesarean deliveries, obviously most people are on narcotic pain medicine, but there's one fascinating study out there where someone said, can we have no narcotic use after C-section? And their answer was yes, we can. 50% of their patients, once they tried, were not using narcotics after a C-section. They were just on scheduled ibuprofen and Tylenol. And that was with appropriate patient counseling, so that patients knew what to expect in terms of pain. That was treating patients' anxiety so that they weren't worried that we were going to let them get into too much pain. It was working on optimizing communication. If you look at multiple studies, they show that on average, patients use 15 to 20 pills after delivery by C-section. And if we prescribe 20 pills, there's no increase in the number of refills that patients are requesting from us. The interesting thing, though, is that if you take that 20 pill average use and you break it down and look patient by patient, you see what's called a bimodal distribution. You've got two different distinct peaks. One set of patients is using very little narcotic. Average is actually 0 tablets. Now, in reality, it ranges between about 0 and 5, but these are the patients who aren't using many narcotics in the hospital, and they go home, they take 2 oxycodone, and then they're done. I saw this patient in clinic yesterday. The other group is typically using about 30 pills because these are the people who are having more pain for whatever reason and need more narcotic. And so if we use one-size-fits-all prescribing and we just give everybody 20 pills when they leave the hospital, we're over-prescribing for half our patients and under-prescribing for the other half. Or actually, in reality, we're over-prescribing for about 80% of our patients and under-prescribing for the last 20%. Over 30 tablets, you're in the 90th percentile for opioid use. So you really need to be thinking strongly before you prescribe more than 30 tablets. If I have a patient who I'm worried about how much they're using, we talk about how to wean off of it. I prescribe them 30 tablets. I haven't been seeing refills in the majority of those patients. GYN prescribing, quickly, hysteroscopy, just don't prescribe opioids. They don't need it. Ibuprofen and Tylenol are your friends. If you look at the data for preventing pain after hysteroscopy, nothing works. Putting paracervical blocks in doesn't help. Giving patients preoperative medication doesn't help. The problem is they just don't have enough pain, which I guess is a good thing. So don't give them opioids afterwards. With hysterectomies, abdominal hysterectomies are a lot like C-sections. Patients on average take narcotics for 9 days afterwards versus the 8 days of C-sections, and typically they're going to use about 20 pills. For vaginal or laparoscopic hysterectomies, these are really similar to any other minimally invasive laparoscopic surgery we do. Patients typically are on narcotics for 4 days and are going to typically take 10 to 15 pills. This is where I've had the hardest time changing my own mindset and saying, oh, it's okay for me to send patients home with only 15 narcotic pills. So how do we change our mindsets? Because that's a tricky one. We're conditioned to say we want to treat patients' pain well, which is really important. We're also conditioned to want to avoid phone calls and to make it easy on our patients so they don't have to come back to the office to get a paper prescription. And so we typically err on the side of overprescribing. One way around this is to ask our patients how many they think they'll need. Put the patient in control of it. They are not going to tell you 150, 90% of the time. What one study found looking at prescribing after C-section was that the average script requested was 15 tablets, based on talking to your patient about what people's typical use was. And sure enough, there wasn't any increase in refill rates. And patients' pain wasn't any higher after their discharge than it was for patients who didn't choose their own prescription, but got the standard prescription. So what do we do when things get tough? Because we all run into those cases where we've got patients where we're having a hard time controlling their pain. These are tips and tricks that I've pulled out of the literature and also ones that I've picked up over practice. First thing to do is to schedule medications if they're not already. I can't count the number of times where I've got a patient who's having pain control issues and I look to see, are they taking their meds regularly? And for whatever reason, their ibuprofen or Tylenol isn't scheduled. If they are on scheduled ibuprofen and Tylenol, see how much narcotic they're taking and then split it. Give them about half of it scheduled and the other half PRN. And that way they're getting it more frequently. The nurse is in there giving it to them regularly. They end up using less. They also get better pain control in the process. Schedule the adjuvants that you're using, whether gabapentin or something else like we'll talk about. When we're talking about scheduling medications, there's no benefit to alternating when you dose your medications. There's a study that came out looking at staggering your ibuprofen and Tylenol versus just giving it on the every 6-hour mark. It works just as well in the every 6-hour mark, at least in the small study that they did, which admittedly only had 100 or so patients in it. But there's at least no significant benefit. And we do know that patients who get more sleep end up having less pain. This is for patients who get more sleep pre-op as well as patients who get more sleep post-op. So if we can keep our patients rested both before and after their procedures, they're going to end up having less pain. If they're not already on gabapentin, add gabapentin. Like I said, I usually give patients a loading dose and then put them on 300 milligrams 3 times a day. That's worked very well for most of our patients. If they have a big abdominal incision, that binder really does make a difference. There's a study looking at the Prevena vacuum dressing that found that it cut opioid use by about 30%. And that's just from having pressure constantly on that incision. So binders are your friend, Prevenas are your friend. One thing that I didn't realize was that magnesium has an effect on patients' pain. So there's some fascinating studies, and this has been replicated multiple times, where for patients who had a C-section, they compared patients with preeclampsia to patients who just had a C-section. And the patients with preeclampsia who are on a magnesium infusion, all other things being equal, use about 30% less narcotic. That's as much as keeping a patient on Toradol. So if you're having trouble with pain control, especially in patients who have an allergy to NSAIDs or something else where you're missing something out of your toolkit, this is a really good option. The problem is that they won't let you run it on the GYN floors. So those may be the patients where you ask them to come down to labor and delivery, where we do this all the time, and we can run them on magnesium. You do not need to use a bolus dose to load their magnesium. You just put them on 2 grams an hour, and it works just fine. Treat the patient's anxiety, because a lot of pain is driven by patient anxiety over, is it going to hurt? How much am I going to hurt? Do I have that sense of control? If we can help patients manage their anxiety, That is really helpful for pain control. But please don't use benzos to do this. I know when I was in residency, there was a lot of, oh, patients having an anxiety attack here, let's give them some Ativan. It works great. The problem is that benzodiazepines plus opioids is conscious sedation. You need special privileges in the hospital to do this IV. We don't get flagged for it when we do it using orals. But if you look at the patients who die from opioid overdoses, the majority of them are co-prescribed benzodiazepines. And so they take their benzos and they feel better. They take their opioids, they feel better. They take them both together and they don't wake up because they both work too well together. Instead of benzos, what are your other options? Visceral and Phenergan are the two that I've found that work really well. In fact, you can do both Visceral and Phenergan. Obviously, if you're going to do this, start it in the hospital. You're probably going to be wanting to send your patient home on naloxone just in case, but you're probably going to be sending that patient home on naloxone anyway because they're going to be on large amounts of narcotic. Other tips that I've picked up for managing pain, paracervical blocks help with vaginal hysterectomies or laparoscopic assisted vaginal hysterectomies. They end up significantly reducing the amount of pain the patient has. So I've started doing this more regularly in my patients. Continuous local anesthetic pain pumps help for the first 24 to 48 hours. I don't believe we have anyone who uses those here. I don't even think we have them available. I've seen people use them before. The amount of pain control improvement you get is some, it's not great. Long-acting liposomal bupivacaine does not have the same effect. It doesn't actually help. Putting local anesthetic into your port sites or even into your abdominal incisions maybe helps for the first 4 hours and then it wears off and it doesn't help with pain after that. Think about tricyclic antidepressants if the patient can tolerate those. If you're doing a C-section or other large abdominal incision and you're worried about pain afterwards, don't reapproximate the rectus muscles, because we know that patients who you do reapproximate the rectus muscles have more pain with movement. It's not a lot more pain, but they do require more opioids. And then I wanted to spend a little bit of time talking about the increasing number of patients we're getting on long-acting narcotics like methadone and Suboxone. These are patients who are getting help. And so we want to keep their pain well controlled, but their livers are used to seeing opioids. So we don't have as easily responding patients to the narcotics that we're giving. First thing, continue their outpatient medication because this will help them stay out of withdrawal. Otherwise, you pretty much have to dose them every 3 hours with narcotics, which means they're not sleeping very well. Then I typically have used oxycodone for breakthrough and it works just fine. However, for some patients it doesn't work, and in those patients it may not be strong enough to compete off the long-acting narcotic from the opioid receptors. So switch over to Dilaudid. It generally works better for breakthrough pain, and those patients will end up doing just fine. Typically you can titrate them down to their long-acting narcotic dose, and my experience has been they actually titrate down fairly quickly in most cases. I wanted to also spend a little bit of time talking about the legal considerations and the new Washington state laws which prompted this whole CME. So congratulations, you've now gotten your 1 hour of CME on opioid prescribing. So save your certificates because if you ever get audited, they're going to want to see this one. If you are refilling a prescription for a patient, you need to check the prescription monitoring program. You do not need to do this for initial prescriptions. If your prescription monitoring program is integrated into your medical record, though, you have to check with every single prescription. So for Care Connect, that's going to be coming in March. We're also required to give patients information on the disposal of opioids because, like I said, most patients are just keeping them around and they don't know where to go with them to dispose them or how to dispose of them. We have to document the reasoning for the number we're prescribing. This is especially important if you're prescribing something that's out of the typical prescription for that procedure. Like we said, please don't prescribe other meds that make a patient sleepy. We talked about benzos. The other ones you have to be really careful with are your sleeping meds, Ambien, Lunesta, basically the quote-unquote Z meds, because you get that same synergistic effect that you see with benzodiazepines. We're not allowed to prescribe more than a 14-day supply at a time. However, if you're writing for Medicaid, things get a little trickier in that they won't cover more than 42 doses, which means 42 tablets, not 42 10 milligram doses, unless you're giving them 10 milligram tablets. So if you've got a patient where you need to write for more of this, you write exempt on the prescription and everything's fine. You have to reassess the patient every time you're represcribing the opioids, and new rules kick in at 6 weeks. Fortunately for most of us, we've got our patients off of opioids or back to their primaries by that point in time. So what are the take-homes from the talk today? If you do nothing else, schedule your pain medications. This is probably the single biggest thing that we can do. The next biggest thing is we can use multimodal therapy, ibuprofen, Tylenol, gabapentin. Please prescribe based on what your patient is actually using. Getting into the MAR and looking at how much the patient is using or talking to the nurse is really important. One of the things with prescribing in the Peace Health system is that the opioid prescriptions are written as a taper up. So the nursing instructions tell the patient to start with one tablet. If that's not helpful, in half an hour, give the patient a second tablet. And then after they've done that twice, they can automatically start at 2 tablets. This is great for your post-op patients initially because it gets their pain well controlled quickly. But it doesn't work well for tapering them off because there's no way to do a taper down. The patient has to actually refuse the medication. So this is where we work together with our nursing partners to say, hey, if you think you don't need all of your medication, let me know and we can step back down to a lower dose. And then they just chart that the patient refused the 10 milligrams, they only wanted 5. I've talked with the Care Connect people about, is there a way to do a taper up and a taper down? The answer is unfortunately no for regulatory reasons. So that's not going to be changing. The other important thing is we need to communicate better with our patients. We need to talk with them before procedures, before they have their babies, about what sort of pain to expect, what's normal, so that they don't get surprised. I had a patient in the office yesterday who I said, oh, you know, this procedure typically feels like a 5 or 6 out of the pain scale. And she's like, all right, thanks for warning me. And she's like, that was it? That was a 3. Like, okay, great. I'm glad I set the bar a little too high for you. Your patients will tell you how much opioids they need. So in conclusion, opioids are overused. And we can safely decrease the amount prescribed. The good news is we're already making a difference. If we look at opioid prescriptions across the country, they've been falling since 2014. Opioid prescriptions here at St. Joseph's and across the Peace Health system are down 30% since October. The only thing that changed since October is we changed the default prescription in Care Connect from 30 pills down to 10 pills. That's the only thing that changed. That and the news media coverage. So people are paying attention. I wanted to give a shout out for our next CME in April. We're going to be following up on this with a discussion on counseling patients about addictive substances. We had the CME last year on marijuana and pregnancy. This one's on opioids. Now we're going to talk about doing those difficult conversations on how to talk to patients about smoking, whether it's marijuana or cigarettes, narcotic use, other addictive behaviors. So with that, thank you very much. I hope you learned something. Doug.
When we send patients home, typically in the hospital they've been on scheduled Tylenol and scheduled ibuprofen. But when we send them home, we're sending them home oftentimes with Percocet, which has the Tylenol in it, and they're not taking that scheduled. And are they then losing the benefit of taking that scheduled Tylenol and ibuprofen at home?
So yes, they are losing the benefit of taking the scheduled ibuprofen and Tylenol at home if you send them home on Percocet and you don't tell them how to take their meds. And this is where communication is super important. The other thing you can do is you can just not send them home on Percocet. Historically, I know I sent people home on Percocet because what I was told by my other residents is it's harder to melt in a spoon and shoot up. That's not what people are doing with this stuff. They're just taking the pills. So I switched back to sending people home on oxycodone because then I can also send them home on scheduled ibuprofen and scheduled Tylenol. I've quit even writing my ibuprofen and Tylenol discharge scripts as PRN. I just write them as Q6, give them about 100 tablets. That'll get them roughly 2 weeks, and that's typically what they need.
On Epic, for the after visit, it just gives Percocet. That's the option, I find.
What?
Not on mine.
No.
That may depend. So that may depend on what the settings for your particular favorites are.
Because
And-
if we have them just on plain oxycodone.
Mm-hmm.
You
Yeah.
have to go over your favorite and facility list. You have to switch it to facility list and it'll give the before and afters thing.
Yeah. If you're using the discharge to home order set for GYN surgeries, that one has Percocet built into it. That's the only one I'm aware of. All the rest of them, if you're going through the discharge navigator, when you do their medication reconciliation, it'll show you whatever they're taking in the hospital. And so you can just hit pluses for the ones that you want, your stool softeners, your narcotic, your ibuprofen, your Tylenol. So if you're seeing Percocet there, then that probably means that your order set is set up with Percocet in it. In which case you have to be very careful with your Tylenol dosing, which is why I've gotten away from using Percocet in the hospital. Shane.
Chad, I don't believe that this is an issue on labor and delivery, but it has become an issue on the board where our order set has pain, like 1 to 2, 3 to 5, whatever, I can't remember exactly what it is.
Right.
But the narcotic generally is in the 6 and above. So if there's sometimes where I prescribed it, they're not getting it because they haven't met that threshold, and how can you explain it to me?
So, excellent question. If you look at the order sets, they have mild, moderate, severe pain.
Right.
And you don't get into your narcotics until you get into the upper level ones. And so how do we get our patients the narcotics when they need them, even at lower pain scores? And in October, one of the other things that changed is they compressed moderate and severe pain together. So right now there's just 1 to 3 and 4 to 7, 4 to 10, which is helpful.
So that's already been fixed.
So that's more fixed. Your patient will be getting narcotic for any pain of 4 or above as long as you've ordered it.
Sometimes you do have to open the box. There's little boxes that say for pain 1 to 3, like 4 to 5, and then something to 7. And what I had done is I redid and saved time where I scheduled Tylenol and ibuprofen, and then I set my narcotic. I did the moderate and severe pain.
Yep.
And I haven't had any issues since I did that, and I saved them.
Yeah.
It's just,
So-
it's using Epic, that's.
So from a cost perspective, is it okay for us to suggest our patients take 1,000 milligrams of Tylenol as a part of the car before they come in for a procedure?
Absolutely. I think that's certainly much more cost effective than giving them IV Tylenol here, and going to be probably saving them $5 in a single Tylenol dose when they come in. I don't know what the hospital charge for Tylenol is, unfortunately.
The problem with doing that is right now anesthesia has it on their orders such to get it done. And so
Right.
all the patients are getting it, and so I just.
This is a GYN patient.
Yeah, so for GYN patients, anesthesia is pretty much routinely loading with Tylenol now, which is helpful.
To me, it's not the place to save money.
If you're coming into the OR,
That $5.
saving $5 is probably not worth it. So,
The IV Tylenol,
The way that billing goes, at least my understanding of billing is that those meds, they may have a $5 cost associated with them, but most insurance companies are getting a flat fee.
right.
And
So-
I also think every.
I just put it on my pre-op orders, and then that way anesthesia knows they got it, and I know they got it. Yep. They do, but they don't always remember, oh yeah, and I took that one extra dose. Or at 5 in the morning, I may not remember to take my Tylenol. Carla.
What I would love is for this to be given to the nurses of labor and delivery, because I'm from the Midwest, and we never prescribed narcotics for vaginal deliveries until I came here. I was like, what? Do they have a hematoma? Do they have a 3rd or 4th degree tear? And then it became in my habit, and I stopped doing it. And then I get calls from nurses thinking I'm crazy because I go, well, is their pain tolerable? Have you given them a heating pads, like a bad period? I mean, the goal, I always tell people, the goal of your pain is not 0. It's I can walk around, I can move, I can do what I'm supposed to, but I feel a little cramped, like you do when you have your period once a month. Now, but the nurses think I'm crazy, and I feel like they need to have, and they'll be like, oh, I haven't tried that yet. And so I feel like they need to be given this.
Yeah.
Because
I think there's a lot of collaboration that needs to happen.
There's a lot of collaboration that needs to happen. I'm happy to come chat with nurses as well.
I tell it to the next nurse who calls me, so I feel like
Yeah, I'm not dismissing what you're saying. I totally agree that there's education that needs to happen, but, because I'm probably the only nurse in there besides all the nurses over there, probably, I'm gonna speak on their behalf. But, you know, just to be really clear, there's a lot of confusion, and the orders that are being ordered on every patient is so different. I mean, sometimes there's 400 milligrams of ibuprofen PRN, sometimes there's scheduled 600. It's so variable, and so what I would love is if we could have a work group that get together and
that's what I was just gonna say.
streamline how we give our non-narcotics, so how we manage our ibuprofen and our Tylenol for our post-op and postpartum vaginal delivery patients. It would be really helpful, knowing that there's gonna be exceptions, of course.
Right.
And the narcotics are obviously exceptions. We're not gonna, don't people come to consensus on that, but I would love that. I think that would be really helpful for everybody, and that also would include more education. I think the reason why they're feeling that way is because, and then to Chad's point, well, after one of our last conversations, they don't want their patients to get behind on their pain medication, but what I'm starting to educate them to is if we had a standardized way of managing their pain with the scheduled Tylenol, scheduled ibuprofen, we'd be using less narcotics, we'd be needing less narcotics because we're all approaching it from the same.
And I'm gonna jump in here and say, we start our CBC advisory committee meeting here in 2 minutes. But one of the things that I was going to ask for is Chad and I have agreed to start being on this task force to develop more standardization in our post-vaginal delivery and post-C-section pain management. Again, part of the problem with that is that we've got a bunch of different order sets and the nurses don't know whether it's Dr. Kaepernick or Dr. Levine or Dr. Dado or Dr. Madison doing the orders. We all have little different nuances in there. And so we want to put together a task force to try and get that all kind of routinely for our routine patients. Of course, there's always going to be exceptional patients on that. But to get together a task force to try and do the same thing that we did with our standard admission labor order sets, to get a standard post-vaginal delivery order set that's kind of and post-op C-section. So contact either Chad or myself to if you want to be part of that task force.
I just had two quick comments. One is, it seems like there may be some room for helping patients as far as the